So
Hello.
you have been in Ottawa. How's that been? Going to meet with real live people and presenting in
We're
person.
together.
I know. We're in the same room.
We haven't stopped talking.
I know. I gave myself a headache because I haven't heard my voice so much because I haven't had anyone really to talk to for a while.
No, we're having a great time. Last night we were at Patterson and it was a great night. Really nice group.
Yeah.
And we had a lot of fun.
Yeah.
And then tomorrow we're at Sinclair with the lasers. We're doing that with them.
Yeah.
And then Sunday we are doing an in-office laser.
Yeah.
So
busy 4 days, but lots of fun. So
lots of fun. Great. We're going for sushi tonight.
Going for sushi.
We're
That's
excited.
Right. Well, we've still got some people joining us, so we'll hold off for a couple minutes, and then I'm really excited about today. And so I've actually been getting a lot of emails from people just saying they're so happy to have Dr. Hassanpour back. So there's a lot of excitement, a lot of buzz around this one, and I myself am very excited.
Yes, you did such an amazing job last year when you were on. I agree that it was one of the largest watched shows that we've had, and we have a huge amount of people that have signed up already to watch it, whether they're getting the recording, and then we always have a lot of people that watch after. So we are so excited that you were able to fit us into your busy schedule and join us today.
Awesome. Thank you for having me back. This is always fun.
All right. So I'm just going to do a little bit of housekeeping here while people are joining in. So we have a full session for today. We have a lot of people joining us. So as always, feel free to type in any questions you have, any comments you have, using the chat function for comments, questions that you have. Maybe use the Q&A just so we can track it and organize it a little bit better. With so many people here, we may not be able to get to all of the questions, but we're going to do our best. I think what we'll do is reserve some of the questions for the very end, and with whatever time we have, we'll kind of go through some of those questions. The session is being recorded, so don't be afraid if something comes up and you're pulled away for a minute, you don't want to miss anything. It will be recorded and available within a couple of business days. So that is all I have to say on the housekeeping side. Yeah. And Carrie, I'm going to hand it over to you to introduce our guest today.
Awesome. Well, I am beyond excited, like I said already, Dr. Hassanpour, to have you back. If you haven't listened to Dr. Hassanpour, if you haven't had that pleasure, I'm going to give you him a little bit of an introduction. So Dr. Hassanpour completed his dental training at the University of Toronto. He received his bachelor's degree in molecular biology in 2008. He completed his first master's degree in bone biology in 2010, and he obtained his Doctor of Dental Surgery degree in 2014. And he finally completed his second Master's of Science degree in innate immunology in 2017. He also completed extensive training in periodontology and implantology in 2017 as well. He is a board certified periodontist and a fellow of the Royal College of Dentists of Canada. Dr. Hassanpour has published multiple peer review articles and is a winner of multiple scientific research and clinical awards. He definitely has a huge passion for education, and currently he is a clinical instructor at University of Toronto for the undergrad and graduate program in periodontology. He also frequently hosts lectures and seminars in Ontario for dentists and dental hygienists. He is a past president of the Toronto Central Dental Society, as well as an executive on the Ontario Society for Periodontology. Dr. Hassanpour is also privileged to serve as a general counselor on the Ontario Dental Association, representing Central Ontario. So when Dr. Hassanpour is not living his dream of all things dentistry, he does have a lovely wife, Kelly, who is his high school sweetheart, which is pretty nice little awesome story. He has a wonderful son who's 3 now, and he has his awesome chocolate lab, Charlie. So Dr. Hassanpour, if you're not looking and thinking and presenting things like this all teeth, we can find you on the golf course, as well as trying to spend as much time as you can with your family, right?
That's it. Yeah, I do this for my family, basically. That's their motivation for all of this. So yeah.
It's kind of fun to hang out with people that love all things dentistry. People are like, really, you want to read that? But I love it. I'm like, I live it, I breathe it. It's like a passion, it's a hobby, it's all things together. And so, yeah, it's nice when our family supports us in all those ways. That's for sure.
I mean, Amazing. Again, thank you very much for having me. This is I had a blast the last time we did this, and I hope that everybody enjoys today's presentation as well. And I really like it because it's like a very much more interactive sort of session. Most presentations, somebody just stands there and just talks for whatever amount of time, and then people ask them questions. But I love this. This is a very dynamic, interactive session. So I hope people enjoy it as well.
Well, I'm really excited that you're going to dive further and deeper for us into soft tissue grafting. So why do you think diagnosis and treatment of mucogingival defects are so important?
Yeah, that's a great question. I'm going to start by sharing my screen here. Hopefully it works. And so can you guys see that? Okay.
Perfect.
Everything's working. Yeah. So, I do have some slides prepared, and this is not a presentation by any means. So again, this is sort of a conversation, and I'm hoping that some of the visual aids that I'm going to provide for you will help sort of with the understanding of the topic that I'm talking about. So I promise there's not a ton of slides. But that being said, your first question is, why do I think the diagnosis of mucogingival defects is important? So to be very honest, I'm a little bit biased. I'm a periodontist. This is what I do. It's one of the things I look for. It's one of the most common things that I treat my patients for, and I have a preference for treating because I enjoy doing it. So I am a little bit biased, but that being said, I think it's often overlooked. People don't look for mucogingival defects. People don't treat. I think they're underdiagnosed and undertreated. And from my personal experience, when I went through dental school before I did my perio specialty, I didn't know what recession was. I mean, I saw people with recession all the time, but it was very little focus on it. And I don't know what it's like in the hygiene community, where when you go through school, how much emphasis is put on, oh, hey, look, there's recession there, or look, there's thin tissue there. What are some of the risk factors that you might want to be looking out for, to whether or not you should be treating these things? And so, I think it's underdiagnosed and undertreated. There's a really interesting statistic that says about 90% of people who are over 60 years old have at least one tooth that has some kind of recession defect, right? Or mucogingival defect. So I think it's prevalent. And so, and I think it's underdiagnosed and undertreated. So that's why I think it's important to recognize it, diagnose it, and then figure out when to treat it.
So how do you decide when and where to graft?
Yeah. And, that's a really good question. And, what I will say is, soft tissue grafting can often be such a overwhelming kind of big concept. But I think if you break it down, there's really two reasons why you'd want to graft. The number one goal, the primary goal of any kind of grafting, is to thicken the tissue. So I hope when you see a case like this, you appreciate that the tissues are thin and they would benefit from thicker tissue, because thicker tissue or thicker biotype is more stable over time. So the number one reason is to thicken the tissue. And the second reason is that maybe when you see a case like this, you notice about, oh my God, there's a lot of recession here. There's a lot of root exposed. So the second reason you want to do some sort of gum grafting procedures to increase the root coverage. And so my hope is that in your day-to-day lives, when you see cases like either of these, you say, okay, something should be done. You may not know what should be done or what the options are, what the best option is, but you say, okay, something should be done. And I want my patient to see a periodontist, or the dentist in my office does grafting. I want them to see someone to do something about this. I find that sometimes, though, you have cases that are like this, where either there's multiple recession defects. Sometimes the recession defects are covered by composite resin restorations. You can't really see the CEJ anymore. There's a lot of crowding. There's a whole bunch of other reasons, and you're not really sure, like, does this patient need to be treated? Can we just monitor him? Like, can we observe it? What needs to happen, if anything? And so what I've come up with is what I call my 4 simple rules for soft tissue grafting. And this is, I hope this video plays out okay, but this is basically, I'm walking you through how I have a consultation with my patient. So the first thing I do is I start by drawing a tooth. And I say, okay, well, the crown is the part of the tooth that's above the CEJ. And the root is the part of the tooth that's below the CEJ. And normally your gum line is at or above the CEJ, and you don't really see the root. But sometimes you have recession where the gum line moves apically from where the CEJ is. And so that's the first kind of problem that a patient can have. They can have gum recession. I suppose also really, really importantly is to find another anatomical structure, which is called the mucogingival junction. The mucogingival junction is a line that separates the mucosa which is this sort of flimsy, thin, elasticy tissue, from the gingiva, which is this sort of thick, pink, that keratinized tissue that is very, very protective. So you have this band of gingiva. Normally, you have about 2 to 3 millimeters of gingiva around your teeth, and that's considered stable. But sometimes you can have less than 1 millimeter of tissue around your tooth, and then you can have a second problem, which is basically called minimally attached gingiva. So I basically draw this, or another way you can think of it is thin gums. So you can take this and basically you can break it down for your patients that you can have two different problems when it comes to your teeth. You can have either recession and you can have thin tissues. And by putting these two together, you can actually come up with the 4 rules. And the 4 rules are like this. So what I do is once I've explained that sort of basic anatomy to the patient, I then will draw, maybe if it will work. I wonder if it'll work. There we go. So I will draw 4 teeth for them. And because there are basically 4 scenarios that you can have. And I always say my first tooth looks nothing like my 4th tooth because my drawing skills are terrible, but it does kind of help the patient understand what I'm talking about. And sorry about all the doodles at the bottom. It's when you're drawing with your hand, it becomes, anyway, so I'll delete those in a second. Yeah, you see there go. So we have 4 scenarios. So scenario 1, 2, 3, and 4. And I'm going to go through the 4 different things that you can have. So we're going to draw the gingival margin with red. So in scenarios 1 and 2, there is no recession. In scenario 3, there is some recession. And in scenario 4, there's probably a little bit more recession than scenario 3. And then what I'm going to do is I'm going to draw the mucogingival junction. So in scenario number 1, lots of tissue. Scenario number 2, not so much tissue. Scenario number 3, there's still a good amount of tissue, even though there's recession. And in scenario number 4, there isn't a lot of tissue again. And so what we'll do is in scenario number 1, we talk about whether or not there is recession and whether or not there is thin gums. So in scenario number 1, there's no gingival recession and there isn't any thin gums. This is okay. This is ideal. This is what you want. You want every tooth to have no recession and lots of tissue around it. In scenario number 2, you don't have recession, but you have thin tissue around the tooth. And that's okay. It's not a big deal, but you have to increase your monitoring because this is a tooth that is potentially at risk of developing further recession. So if there's certain risk factors, which I'm happy to talk about, but if there's some risk factors, then this tooth is a tooth that you might be worried about getting recession, but you're going to increase your monitoring. You're going to put a check mark next to it saying monitor it. In scenario number 3, you have recession, but you don't have thin gums. And ideally, you want to do a soft tissue graft here to convert the 3 into a 1, where you can bring the gum line up. And then scenario number 4, you have a combination of recession and thin gums. Again, ideally, you like to do a gum graft here. If you can, take the 4 to a 1. But if you can't, at least you want to get it to a 3, because when you have thick tissue, it's more stable than having thin tissues around the tooth. So this is like my 4 simple rules. And giving credit where credit is due, I got this from a wonderful periodontist, Dr. Omar Osman, who I worked with for about a year, and he taught me this. And it is such a simple way of looking at mucogingival defects because you just go 1, 2, 3, 4. And in 1, you don't need any treatment. In 2, you don't necessarily need treatment unless there's certain risk factors. In 3, you could graft it predominantly to get it into a 1, but this is a stable site. It's probably not going to get worse very quickly. So if you had aesthetic reasons you wanted to treat this, you had a patient who had a lot of dental hypersensitivity, you could use that as an opportunity to treat with a gum graft. But in scenario number 4, you probably do want to treat this because if you don't treat it, it probably will get worse. So in terms of longevity, a tooth that has a lot of recession on it already and a tooth that has thin tissues will probably get a little bit worse. Okay, sorry guys, I have to take a little break. I gotta plug my computer in. My battery is gonna die in a second. Thanks, bud. All right, just give me 1 second. Let me just plug this in.
Ladies, this makes so much sense. I can totally see how I can actually apply this, and I'm speaking real terms. Like we have to know all the classifications, but this is something that we can actually do, something that we can educate our clients on. Like this is good stuff. Like, you know, I'm really glad that you've taken this and you're sharing this with us, because I think that this really does make sense. It's like from 3 to 1, from 1 to 4 would be ideal, but you know, this is great information.
Yeah, I mean, I'm glad you brought the classification up because there's 2 different classification systems that in the dental world, at least periodontists use. I'm not sure if hygiene uses it. And I don't really expect hygiene to use it. A lot of dentists don't understand it, but it's the Miller classification. And then there's the Chiral classification, which is the newer one. So Miller goes 1, 2, 3, 4, and it's not the same as this 1, 2, 3, 4. And the Chiral goes 1, 2, 3, which is again, not the same as this 1, 2, 3. This is just sort of this is my way, or Omar's way, let's say, that we find a very easy way to try to parse down the problem and then sort of say, break it up, categorize it. So it's easy for the dental professional to understand and easy for the patient to understand, and then to motivate the patient as to whether or not they should get that kind of treatment. So I have a case here, and I'm actually going to kind of walk you through this case, because this is a case that has a ton of recession defects. And what I'm done in orange, I'm just going to draw you guys the mucogingival margin. And, you can argue that my line is wrong, but so draw your line wherever you think your mucogingival junction is. Usually it's the border between the pink and the red. And then what I'm doing in blue is I'm marking out where I think the CEJ is. And in some of those areas you see I put dotted lines, is because either the CEJ is not very obvious, or there's composite resins where that is masking the CEJ. So wherever I put the dotted line is where I think the CEJ should be. And then what I'm going to do is I'm just going to go through every tooth and say, okay, these are ones where there's no recession and the tissue is thick. So there's at least 2 to 3 millimeters between the gingival margin and the orange line. Then I've done the 2s where I think, okay, you know what, there is no recession, but I think the amount of tissue is pretty thin. So maybe these are some areas that I'd maybe want to monitor in case the patient is, let's say this is a patient who's going through orthodontic treatment. So maybe those areas might get worse with ortho. So just keep an eye on those. And then I mark out my 3s. These are areas that have recession, but they have a decent amount of gum around them. And so, yeah, we might treat them. Predominantly, if our major reason for treatment is aesthetics or sensitivity. And then I mark out the 4s, and I do those in red, because those are ones I'm like, okay, you know what? These have recession, and I think the tissue around them is a little bit thin. So if I had to start with one area to treat, I'm going to start treating the 4s. And so you can see we go from a patient here that has lots of different recession defects. This isn't a simple case where it's like a single isolated defect. And so keep in mind, treating these requires surgery, and you can't do it all in one surgery. So, and surgery has recovery, and it certainly has a cost to it. So, if I had to want to treat every single one of these teeth, this is a $10,000, $12,000 treatment plan. And a lot of people don't have that kind of money laying around to treat their gum grafts, especially when they don't notice it or they don't care about it. This is a patient who came to me and said, I'm going to get ortho. My orthodontist is worried about my gums. What should I do? And so instead of treating every single tooth, you say, okay, you know what? You should start with the 4s. Let's treat the 4s, and then we can watch everything else, because the 4s are the ones where there's recession and there is very thin tissue. So chances are they're going to get worse. So let's start dealing with those first.
Brilliant.
So that's sort of that. Yeah. So I'll leave it at that. I mean, I do have more cases that I can go through if you guys want, and kind of do it live. But if I don't know, I hope that makes sense. This is.
Yeah.
Oh yeah, that's excellent. Excellent. So it's not only, it's really important to not only have the full periodontal evaluation, if you have the ability to take pictures and explain it the way you did, then it makes it so much more sense to our clients and makes it easier for them to understand the buy-in that's needed for this correction to happen.
Yeah. I mean, sometimes you're absolutely right. I mean, I never practiced without pictures. One of the greatest things that I learned how to do was to take good, high quality intro photos. Like even get your iPhone with a ring flash on it, it'll work, right? You don't need to have a DSLR, but you don't need a fancy $3,000 camera. You just document it however you can, and then upload the picture and put it on the computer screen with the patient. If you have the opportunity to annotate on the slide, amazing. If you have a tablet or a pen or whatever, but even not, you just print it out and just draw it on it. Like there's so many ways to do it. I find that like sitting there with your patient, like those little doodles that I drew for you, I actually do it in front of the patient, and they laugh at me because I always tell them I'm not a good artist, but they kind of engages the patient and helps them understand why some of these treatment recommendations are being made. And then it really helps them sort of be a part of their whole treatment plan, as opposed to having just somebody say, oh, you need to graft and you need to do it here because I said so, kind of thing, right?
Yeah, because it's like, instead of just saying that, which we hear that all the time, you need to have this, you need to do this.
Yeah.
But you've educated, you've shown them the 1, 2, 3, 4,
Yeah.
and then you've taken their mouth and you're showing them all the 4s, because you've just showed them how the 4s need to at least become a 3.
That's right.
Here, you're not saying you have to do, the whole second quad buckle. You're saying
Right.
these are the ones we have to do.
Right.
So I think it's brilliant.
I have a question
Sure.
from this. I'm just
Yeah.
sort of thinking, the way you've drawn it here, the way you've
Yeah.
explained it just seems straightforward. Okay, it makes
Yeah.
sense. But yet it's not a subject that's straightforward, and it's not a subject that always makes sense. So
Yeah.
do you think that there's maybe some myths that have sort of trickled in that have caused some confusion, and could you speak to those?
Yeah, sure. You know what? I'm gonna close out the slide and I'm gonna go to my myths. Oops, sorry, I just stopped sharing, didn't I? Okay, so that's okay. I will go to that slide. I have a myths slide that I put up, and I think it has so let me do this. Okay, am I sharing my slide right now with you guys or no?
Not yet.
Not yet. Okay, sorry about that. Give me 1 second. Okay. Can you guys see this?
Yes.
So I think these are the 4 biggest myths when it comes to grafting, at least when it comes to my my experience in my practice. So the biggest one I hear is our grafts don't work. Don't do grafts because they don't work. And I don't know how to say it. It's sort of, they do work. They are very predictable, but as with anything else, case selection is important, experience is important, and most importantly, by far, is setting expectations. So, if you try to graft a tooth that's not amenable for grafting, it's not going to work. If you don't have the experience or the technique or the know-how of how to do it, it's probably not going to work. And if you don't set your patient's expectations properly, you're going to have a disappointed patient. So this is what I say to my patients when they come in. And at the very beginning of this presentation, I said the primary goal of soft tissue grafting is to thicken the tissue, right? If I have a 4, I want to take the 4 to a 3. That's my goal. Like, I don't care if I don't take 100% root coverage. I mean, I know the patient cares. The patient's primary goal is my gum line is way down here. I need it to be at the CEJ. And so if the patient goes into the procedure with the expectation that the gum line is going to get 100% covered, and then you as a provider fall short, then the patient is going to say my graft didn't work. But if you tell your patient, listen, I'm going to try to get as much root coverage as I can, but even if I don't get 100% root coverage, I'm going to be happy with as much root coverage as I possibly can get. But if I can thicken your tissues and I know it's going to be stable, then I consider that a success. So I have this, what I call the unofficial 80-80 rule. So I tell the patient, I have 80% of the time, I'm going to get 80% coverage or more. And if you're okay with that, then let's do it. But if you want me to guarantee you 100%, you know what? There's 5 other periodontists in my neighborhood. I'll give you the name of all of them and go see them. And I'm not trying to be like, oh, I'm whatever, right? I don't need you. I don't want you. But I always set the expectations. And so if you treat the wrong case, if you don't know what you're doing, and you don't set your patient's expectations, people may think grafts don't work. But again, in my hands, I have about 1 to 2 failures a year. And in which case I'll retreat them at no charge. And again, those patients are usually they work out. So that's one big myth. The second one is that grafts hurt too much. And again, it's true. One of the biggest reasons people don't get grafting is, oh my God, this hurts like crazy. Like, I'm never going to do that again. And what I tell my patients is that you're absolutely right. Anesthesia on the palate hurts a lot. And if you do it in a proper way, where you put a lot of pressure, inject slowly, put a lot of topical anesthetic on, it is uncomfortable, but people can typically tolerate it. But more importantly, when you let the patient go, if you don't cover the palate with something, it'll hurt a lot. And so let me just see if I have an example of it. So here, oh no, where is it? Did I not have it? Oh no. Oh, there it is. Okay, perfect. So can you see this? So I've got some photos here. So on the far left, the first 3 pictures are on day 0, like the day of the surgery. So on the far left, you can see that's me harvesting the graft. So looks kind of nasty, I guess. But basically, you can see that this is the palatal tissue here, the surface epithelium of the palate. This is the roof of the mouth back here, and I'm making 2 parallel incisions here, and I'm taking out the tissue in the middle. Hopefully that you can see that. So the graft doesn't come from the surface, at least not a connective tissue graft. It comes from the middle tissue. But by the time that the patient leaves the office, they leave on the far right of that where you have that green stuff. But even if I did any of that stuff, you can see when I suture it, this incision is the incision line is very, very small, and it's very clean. So, for them to recover from a small incision like that, usually it's not that bad. And I say usually, but everybody's pain tolerance is a little bit different. But even if I let the patient go with just the stitches there, it would feel like a really bad pizza burn for about a week. And so what you then do is you put some glue, you put a sponge. You can see underneath this green, there's a white thing here. There's a little sponge there that's underneath the green, and you put the green thing on top as a wax. And you just kind of glue that on top. So it's like a Band-Aid. And so when the patient eats, drinks, and talks, it doesn't really hurt them. And then the Band-Aid stuff usually falls off after about a week. And after 2 weeks, when that same patient comes back, the palate is completely healed. So by physically protecting the roof of the mouth during that first 7 days where the experience is the worst, patients don't complain. An incision made with a sharp instrument doesn't really hurt that much. So again, I don't want to gross people out, but imagine you cut yourself with a really sharp knife. When the cut is very clean, it doesn't really hurt that much. It bleeds a lot, but it doesn't really hurt that much. When you cut yourself on a rusty nail, that hurts a lot. All right. So again, the incision itself doesn't really hurt. So if you have someone who has experience, knows what they're doing, takes a quick, clean graft, it's not that bad. And then especially when you protect the palate. So that's what I'd say when someone says it hurts too much, because I've had patients who come in, I've done like 6 or 7 grafts on them. And, if it was that bad, they would never come back.
How do you talk to them about, like, do you find that you have a lot of patients coming to you and requesting that they have maybe like donor tissue rather than, how do you basically walk them through this to?
Yeah, so I tell them about that. So again, that's the fourth one, more fourth, the donor tissue or pinhole or whatever it is, it works better. And again, I will preface this, I am extremely biased. So I like autogenous tissue. I like palatal tissue. I think it works better. And that's the lowest level of evidence. Like a person's personal beliefs is the lowest level of evidence. So if you look at the literature, the gold standard technically is the palatal tissue, but only by a couple of percentage points. The next best is the donor tissue. So donor tissue does work. Donor tissue is a very, very good option. But I will always say that in my experience, that donor tissue has more complications. Slightly like percentage wise, it's not that much more complications. The problem that I have with donor tissue is that when it doesn't work, it's really nasty. Like it looks really bad. Like it almost looks like gangrene, like the tissue necrosis, and it kind of turns into like this big infection. The patient will be fine, it resorbs, they go on antibiotics, it'll be fine, but then it looks kind of nasty for a couple of weeks. Whereas when the palatal tissue gets infected or fails, it proportionally doesn't look as bad, and the patient's recovery is a little bit easier. The other thing is that donor tissue, I think, is actually technically more sensitive because it's not living tissue, so you have less room for error. So again, if you don't have a lot of experience, it might seem easier that you don't have to harvest from the palate. So I'll just get it out of a box and I'll just stuff it in. It's totally fine. But if your sutures pop, or you don't place it properly, or you leave the graft exposed, then you're going to be in trouble. So again, I don't try to talk people out of donor tissue. I tell them donor tissue works. I think the complication rates are a little bit higher. The complications are a little bit more severe when they occur, but when it works really, really well. And if the patient says, you know what, I understand all that, but I don't want you to touch my palate, I'm like, no problem. I have donor tissue here. But I'd say 99 out of 100 cases that I use palatal tissue. And that's because I break down the myth that, oh, it's going to be so painful because, the palate hurts so much. And truly speaking, my patients complain more about the recipient site, which is where the graft gets placed, than they complain about the palate. And the recipient site prepared the exact same way, whether using donor tissue or palatal tissue. And so that's the second myth. than the other bits. The last thing I'd say is that grafts don't look good, and that's because people think grafts look like this. So if this is a connective tissue graft I did on 112, 122, or actually the 23. The 23 has been canine lateralized. So I would say that looks pretty good. It looks pretty natural. Maybe if you looked at the picture on the right and I didn't tell you there was a graft down there, you maybe not know that there was a graft there. So I think when a graft is done with like a connective tissue graft is done, it looks quite good. People think of this kind of graft, which is a CTG, FGG, which is, they call it the slug graft or the elbow patch graft or the whatever graft, right? Where there's big, bulky, thick tissue. But even then, if it's done right, I don't think that looks that bad. This is you can kind of see the outline of the graft. And so I can see people can maybe not be happy about that, but you're right. So I always say to them, what kind of graft are you talking about? Are you talking about an FGG, which looks like this, or are you talking about a CTG, which can potentially look like this? And so those, in my opinion, are the biggest four biggest myths for grafting.
We did have a comment. I know that you have pinhole there. We did have some, I think it was a bit of a buzzword for a while now. Would you touch on that just a little bit?
Yeah, again, I will preface this again with my biases, right? So, please don't take this as like literature based, whatever. So this is, again, on a hierarchy of evidence. This is way at the bottom. This is my personal opinion. So don't sue me. I don't have pinhole training. So pinhole is a surgical procedure where you achieve root coverage by making a vestibular incision. So I want to see if I have a picture of a vestibule anywhere I can show you. So, okay. So, oh, geez, I stopped sharing again. Sorry, guys. Okay. Let me go here and I'm going to share this. I'm still not sharing here. One sec. Sorry, guys. Okay, here we go. Oh, man. Technical difficulties.
Welcome.
Okay.
Part of the gig, I think.
Part of being a Zoom. Okay, so here's an example here. This is a patient that we treated with a gum graft. There's a couple of comments I want to make about this case in particular, but I'll just talk about pinhole with this case. So imagine this patient. So let's look at the canine, the upper right canine, the 1-3. So there's some recession on that canine, right? So normally the way you would do this graft is I would go in and I would, make a tunnel or make some sort of incision and then slide my graft in there. But for a pinhole, you would go really, really high up, sort of in the vestibule. Let me see if I can get here we go, laser pointer. I wonder if this will work. Can you guys see this laser pointer? Yeah. So you would make a little incision here about 1 millimeter thick. Or wide, and then you would use instruments from the top down, and you would come in and you would sort of release this tissue in this area, and then from the very top you would stuff in either alloderm, like a dermal donor tissue, or a collagen sponge or something like that, and it would kind of it would weigh the tissue down. It would kind of using gravity and some releases, it would kind of bring but you don't do any stitches. You leave that little incision at the top to heal on its own. You don't have any stitches around the gum line, so it's like the needle. They don't call it needleless. They call it the sutureless, graftless gum graft or whatever. And so I think it does, in certain applications, it does work really well. I personally don't think it works very well in the mandible because it does rely on the gravity. So imagine you trying to treat these two lower incisors. You stuff tissue from the bottom up and it's just going to fall back down because there's nothing holding it up. I also think it works really well for multiple recession defects. So let's say you have a case where you have, all from 6 to 6. And you need to treat that, then that's maybe an application where it works really well, especially in the maxilla. I also think it's dependent on having really, really good tissues. If you have really, really thick attached keratinized tissue, then it works really, really well compared to having really, really thin tissues. And so again, I'm not pinhole certified. I don't do pinhole. I don't offer it. So when people come and ask me for pinhole, I say I can't do it. I tell them what it is. I tell them I think it's not as predictable as doing a regular connective tissue graft, and so I'll just kind of leave it at that. So that's sort of my personal bias with it.
No, that was a good explanation.
Yeah.
The one thing I want to say with this case is that this is an exact example of setting the patient's expectations, right? So I would argue that this is a successful graft because I took the 31 and 32 and I got almost 100% coverage, but I think we could all agree that we've thickened the tissue here. But if the patient was expecting 100% root coverage at the 31, they would say this graft didn't work. So, the reason why this patient had the graft is because she had a lip ring on the front that was traumatizing the tissue. We took the lip ring out, she let it heal, but then we grafted it. So this isn't going to come back. It shouldn't come back because the source of the the recession is gone. And so, but again, I would argue that somebody could say, well, you don't have 100% root coverage here, and so you failed. And so let me see if I can get a pen here. So this is the CJ right here, right? So there is still, so this was the CJ before, and this is the CJ before. And so, but there's still some root exposed there. So again, if the goal was 100% root coverage at both sites, we didn't achieve it. But I would argue that this is a very successful graft.
So then would we take it that oral piercings is on your list of risk factors for developing mucogingival defects? And then, you know, can you tell us more so we could recognize them as well?
Sure. Yeah. So oral piercings for sure. So here I have a list of, so these, if you want to take a picture of this or whatever, I don't know, like screenshot this, but this is, I think, a good one, where you have predisposing factors. These are things that are almost like genetic. You can't control them. So having thin bone, having malpositioned teeth, having a thin biotype, having thin tissues, and having frenum pulls, those are things that you can't control, but they contribute to getting mucogingival defects. And then there's things that you can control, like aggressive brushing, having oral piercings, having, you know, poor oral hygiene, plaque-induced inflammation, orthodontic movements, and subgingival restoration. So I have examples of this. So this is a dehiscence. So again, this is like knowing when to treat. So this patient came to me for a gum graft on 2-4. And so imagine if you took away, you peeled away the gums, you can imagine obviously there's no bone covering this tooth. And to make matters worse, there was a 5 millimeter pocket on the mid buccal of this tooth. So this person had like 11 millimeters of recession plus 5 millimeters probing up. So there's like zero attachment on the buccal aspect of this 2-4. So this 2-4 is a hopeless tooth. So if you try to graft this, it's not going to work, right? So obviously, so don't graft. I didn't graft it. Another one is tooth malpositioning. So if you look at tooth number 4-1, there is maybe 1 millimeter recession, but then looking at it from the front is one thing, but look at it from the top. You can see the 4-1 is clearly malpositioned, right? It's clearly outside of the buccal housing compared to the other teeth. So I didn't graft this patient. I sent it to the orthodontist and I said, hey, bring this tooth back into the arch. And if there's still recession, then we'll deal with it. So again, recognizing that's a risk factor. Having a thin biotype. So some people have this really thin, scalloped, pointy gum tissues. And so recognizing the patient has a thin biotype is a potential risk factor as well. You're not going to change the biotype for every patient. You're not just going to graft every single site to make them from a thin to thick, but you're going to recognize that this person, for instance, if this person is going through orthodontic treatment, I'd be concerned about the areas that have thin biotype because chances are they're going to get worse. Frenum pulls, obviously. A lot of the time people get sent to me for frenectomies. We don't need frenectomies, but when the frenum is attaching at the gingival margin, that's a risk factor for getting recession. And you can see on the picture on the right, when you pull the lip out, you can kind of see, and I really pull the lip. Like sometimes people just like could just kind of gently pull the back with the mirror. I grab with my 2 fingers and I just pull. And so when the gingival margin blanches like that, and you can also see how much inflammation there is in the margin and how much plaque is built up because this person can't clean that area, right? So that's a big risk factor. So you want to treat that as a part of your treatment plan for the whole patient. We talked about the oral piercings. You know, back to periodontal disease, right? I mean, as a periodontist, I mean, I see this all the time, right? So people have recession, but why do they have recession? It's because they have subgingival calculus and they've lost attachment. Then, you know, that's one reason. Orthodontically, right? Orthodontically, patient starts off on the left, not a lot of recession, tooth gets moved out of the buccal housing, now they have recession, right? Sometimes it's fine. As long as the patient knows that there's a risk, we can treat this. I can treat this, it's not a problem, but it's something that the patients have to be aware of. And then subgingival restorations, right? So, you know, you can see, I mean, yeah, this is iatrogenically induced, right? So there was a decay underneath the crown. The dentist did their best to try to restore the decay, but unfortunately, really, really thin tissues. And then they put the restoration sort of, let's say, a bad margin, let's call it. And then now that can create a lot of problems for the patient. And that's those are my biggest risk factors. I'll also go back to the slide again. So those are my biggest risk factors for developing mucogingival defects.
I really like how you mentioned about pulling the lip out, and that's something that I've done for many years. And it's a great way to show patients the frenum pull because they can physically see that blanching. And you do have to kind of give it a good stretch. And, if you're not comfortable, bring the dentist involved, and those are good reasons to refer. So I always get the questions, what do we do with patients after they've had a graft? What is the best way to care for the grafted area, whether in all the different procedures that are done?
Yeah, sure. That's a good question. So let me bring this up. See, I figured out how to fix this, right? So let's look at a case like this, right? So here's a patient here who has multiple recession defects, obviously, and so this is one of those things where traumatic brushing is a factor for me. So off the time, I get patients who present with minimal recession defects. So let me show you this one. So I'm just give you an example. Oh yeah, perfect. The slide before. So you have a patient that shows up like this, and the dentist says, patient came to me and says, my dentist told me I have recession because I brushed too hard. I'm like, I don't know. Right. So there's some recession on the 1.6, 1.5, 1.4, maybe a little bit of recession on the 2.4, 2.5, 2.6. But I don't see that notching that you see in this case, right? You can visualize where that hard bristle toothbrush was at some point on this person, right? I mean, I'm not saying it's the only factor, but it's one of the factors. And so for me, traumatic brushing is a really, really big risk factor for developing recession. And so one of the things I educate my patients on is how to care for a grafted site after you treat it, because, pink tissue is not resistant tissue, right? So if you abrade it, it will go away. And so, I always say using an electric toothbrush is the way to go. Two reasons why I like electric toothbrushes better. Number one is that they have a pressure sensor built into them. And so especially the new IO toothbrush by Oral-B, they have 3 colors. They usually used to have like red, whereas like you're too strong. And so I always joke, my wife is like 5'2", 100 pounds, 110 pounds. And so she's so aggressive though. Like I get her a new toothbrush head, and within a week, it's like all splayed out. It looks like a what, the troll doll kind of thing. And her toothbrush is like red the whole time. And I'm like, hell, like Jesus, take it easy. Right. So this is really great because it tells you if you're not pressing hard enough, which is going to turn white. If you're pressing good, then it's green. And if you're pressing it's like red, it's too hard. So I love the pressure sensor. I love the instant feedback. But you don't have to have the IO. You can just go with the other one, which is like when the red is good enough, like red is too hard. But that's one of the reasons I like it. The other reason, it has the built-in timer in it, right? So you brush for 2 minutes, right? But there's actually science behind it. So there's actually a paper that was published in 2016, and what it showed is that they looked at sites that were grafted, and then they looked at the gingival margin stability after the graft, and they compared a soft bristle manual toothbrush to an electric brush, to an oscillating rotating toothbrush. And they treated patients who had middle class 1 and class 2. This is not my 1, 2, 3, 4. This is Miller 1, 2. And basically you can think of it as a 3 recession defect. Okay. And they randomly assigned the patients to either getting an electric toothbrush or a manual toothbrush. And then they follow them up for 6 months. So what did they find? Number one, which we all know, electric toothbrush results in a better plaque score and less bleeding compared to manual toothbrush. Like I see that in my patients who, one of the questions I have in my intake is, what kind of toothbrush do you use? Manual, electric. I don't ask them what kind of electric. I just say manual, electric. And I make sure it's a sonic electric, not like a spin brush, like a Crest spin brush. Is like my son uses one of those like $5 ones that are like spinning. So not that, but like an electric, like a sonic electric toothbrush. And so we know that they do better in terms of less bleeding and more efficient plaque control. But most importantly, this is really, really interesting. So complete root coverage, where you go from a 3 to a 1, 100% root coverage, was achieved more frequently in patients who were having an electric brush versus a manual brush after 6 months. So it was like a big difference to like 30%. So this is the same provider doing the same kind of graft on the same kind of people. And then they do it and then they send them off and they bring them back 6 months later. And the people who were using a manual toothbrush tended to get less root coverage than people who were using an electric toothbrush. So that tells you that people who are probably brushing incorrectly. So your brushing technique is really important. And I think there is less human error or less participant error when using electric toothbrush, because it's simple. You just put it on the tooth and you just kind of let the toothbrush do the work, as opposed to you're not scrubbing. I don't know how many people actually use the modified Bass technique correctly. Like I certainly wouldn't. Right. I mean, I'm not going to sweep and, whatever. I'm not going to do that. So it's just so much easier for me to just put the toothbrush and let the toothbrush do the work. So, yeah, so that's what I say. So my post-surgical care, first of all, is for the first 2 weeks, absolutely no brushing, no flossing with anything. You let the area heal. Such a pet peeve when a patient comes back and says, oh, one of the sutures came out when I was brushing. And I'm like, well, why were you brushing? Like, don't touch it. I told you not to touch it. So, but yeah, so don't brush and floss for the first 2 weeks after the surgery. After the surgery, for the first 2 weeks after I take out the sutures, I actually do give them a soft bristled post-surgical toothbrush. I don't tell them to use the electric toothbrush, and I just tell them very gently, supragingival plaque control with a soft bristled manual toothbrush. And then after 2 weeks, they're on it and they can start using an electric toothbrush. And if they don't have an electric toothbrush, I tell them they should get one. But at the end of the day, it's, you can't control it. And I'm just, okay, if you're going to use a manual toothbrush, make sure you're not brushing the gums. So sometimes people say, my dentist or my hygienist told me I should be massaging my gums with my toothbrush. And I kind of cringe. And I'm like, no, make sure the toothbrush is sitting at the junction of the where the tooth meets the CJ basically, and the gingival margin, and just sweep away from it. So I don't like massaging the gums with the actual bristles of the toothbrush, because people don't do it correctly and they'll end up causing more harm than good.
So I'm just thinking, like, with the recession, could it recur? Like you said, like once you fix a lot of the risk factors, that's it, like with the oral piercing and that. But can it come back? And then what do we do as dental professionals to educate our patients, like with the maintenance of, like you do say, like for me, I would say that, yeah, get on the power, but like, is there anything else that you would say to them or have them do after to prevent it from recurring?
I'll just leave it on the slide. I don't even know why, but basically this is not to do with your question, but basically it's a great question. Recurrence rates are typically pretty low. Soft tissue grafts are stable, like a free gingival graft, which is that slug graft, the elbow patch graft. I mean, those things are never going to go away. Like you've had patients 40 years ago, they've had these big honking grafts and they don't go anywhere. So those things are super stable, but typically they're not done to get root coverage. They're done to thicken the tissue. A connective tissue graft or a root coverage procedure is pretty stable. I will say that when people use the donor tissue, there tends to be more recurrence. So after about 8 to 10 years, the tissue does kind of dissolve a little bit, and the patient may need to have a repetitive procedure. So that is actually been shown in the literature. So anytime I do use donor tissue with my patients, I say, hey, listen, there is some evidence that you might have to redo this. For a palatal graft that's used for root coverage, it doesn't typically recur so long as you control the risk factors. So again, make sure the patient is not traumatically brushing their teeth, making sure that there's no, if they're doing orthodontic treatment, they're doing it in a controlled manner where it's being observed. If there's any areas where they're like, 2s and 4s where the tissue is very thin, you either pre-orthodontically graft them or you monitor them very closely. So like, as long as there's no major risk factors and the graft works, it tends to be pretty stable. So my protocol for my patients is that after I do a graft, I bring them at 2 weeks, 2 months, 6 months, and a year. And I follow them up with that. And in the first year, you almost, whatever you get at 2 months, you get at a year. And, patients don't really like to come back after a year if you just want me to just take a picture of a graft, but sometimes they do come back for other things. And I've had patients who I've grafted like 5-6 years ago and the grafts are still stable. And so, so long as the risk factors are controlled, it's very uncommon for them to recur.
So a question for you, when a client had a gingival graft, how soon after can I scale or clean that area?
So I would say what kind of graft. If the graft was done to thicken the tissue where it's below the gingival margin. So let me go back to this case here. And so let's look at this graft here. So there's 2 grafts. No. Okay. Let's look at this graft here. So this is a patient who had a soft tissue graft done. And so this is a graft that I would be comfortable scaling 8 weeks after, 2 months.
Okay.
So for the first 2 months, it's supragingival plaque control. And so that's really important. This is another graft. Again, same thing. This is an FGG, so you can see the difference. Again, I would say probably around 8 weeks, although I'd be a bit more comfortable doing subgingival scaling on this one a little bit sooner. But I think just as general rule of thumb, 8 weeks is a good amount of time to go back and probe or do subgingival scaling, instrumentation, and even orthodontic treatment. Orthodontic movement's usually about 8 weeks. So a lot of times people come in pre-orthodontically, and 8 weeks after the graft, we can let them start moving the teeth around.
That's great.
Yeah.
With everything that you've talked about, like you've kind of talked about some of the, like for me watching this, it just makes sense to get the grafts. And you've talked about some of the reasons why patients might be a bit reluctant. Like you mentioned the cost and sort of some of the myths. Are there any other reasons? Like, I'm just thinking of us as dental hygienists. Is there any other way we can be prepared to help clients who might be feeling a little bit reluctant to have their grafts done?
Yeah. So, I mean, I see it all the time, right? Patients come in and, they sit in the chair, and after I tell them what the procedure is like, they're looking out the window, like, how soon can I run out of here, kind of thing, right? That like, I don't want you to do this to me. Like, don't touch me. And that's fine. I mean, at the end of the day, our job, I think, is to just educate our patients, let them know what their problems are, and tell them what we feel is the best treatment option in terms of grafting. So once I finish drawing the little doodles of the 1, 2, 3, 4, the next thing I do is I say, okay, now you have 4 options. And option number 1 is to do nothing. And no treatment is always an option. But I always say to them, it's not just no treatment, see you later, thanks for coming. It's no treatment and monitor, right? Come back and see me again in a predetermined amount of time. Usually I say 6 to 12 months. Most of the time it's 12 months. I say, listen, I'm going to give you your first option, which is do nothing. And I'm going to give you 3 more options. And if you don't like anything I say to you, then come back and see me again in a year. And so that I can take another picture, because what I will do is that I have many cases where I have one, year 1, and then, a year later, or day 0 and a year later, and I put them side by side. And I say, okay, look, like if either stayed exactly the same or it got worse. If it stayed the same, then okay, see you again in a year. But if it's gotten worse, that hopefully motivates the patient to do something about it, because they can see it with their own eyes that, okay, in the last year, things have gotten a little bit worse. And with recession defects, I don't want to generalize, but generally speaking, they don't get worse that quickly. They kind of slowly get a little bit worse. And the amount of deterioration that tends to happen in a year is still within the realm of treatment. Like, it's not like it's going to go from treatable to untreatable in a year, typically. But if I'm really concerned that things are going to get worse and the patient is really reluctant to do anything, I say, okay, come back and see me in 6 months. So sometimes I do shorten that interval. So the first option is to do nothing and monitor. The second option is to do some sort of desensitizing, because sometimes when patients come in for a graft, it's basically because their teeth are really sensitive. They can't drink their coffee. They can't have ice cream. When they brush their teeth with cold water, it hurts. So, topical desensitizers, sensitivity toothpaste. I like the stannous fluoride toothpaste, the gum detoxified, the gum sensitivity works really well. Or you can do composite restorations, like class 5 restorations on the teeth. I'm not a big fan of class 5 restorations, but if the patient's not happy with the aesthetics, where they see the yellow-white demarcation of the root and the crown, and they want to put a white tooth on it, I think the teeth look too long. They almost look like Dracula teeth, especially if they have like really, really big smiles. But I also think that if done improperly, they can leave a ledge, and that ledge can lead to plaque accumulation and inflammation, which can lead to more recession. I challenge you to go next time you see your patients in your chair, look how many times they have a class 5 restoration that you can see the exact boundary of it. And then right above it, you have recession. I see it all the time, and I guarantee you when that restoration was placed, it wasn't placed. The gingival margin was right at where that restoration is. And so that's why I don't like class 5 restorations. But I mean, a class 5 restoration, I don't know how much it costs. Let's just say $150 as opposed to $1,500 for a graft. Like, it's a huge difference, right? It's a factor of 10. And so I always say desensitizers, composite resin restorations is your second option. Third option is to do a graft using palatal tissue for the reasons why I explained. And then the fourth option is to do a soft tissue graft using an alternative, pinhole, donor tissue, Emdogain, whatever. And so, and I always say, if you don't want to do it, no problem. Option number 1 is always an option. Come back and see me again in a few months, and then we'll take another look.
I love that just shows how you're partnering with the client or the patient. You're bringing them in, you're not dictating, you're not pushing an agenda. Yeah. And honestly, I'd have to acknowledge you a little bit here. For the time that we did work together, I saw how you were interacting with your patients, and you brought them in, and it was this partnership, and they never felt like you were pushing or scaring them into anything. And really respect how you approach your treatment plans.
Yeah, thank you very much. I mean, I always, there's sometimes people said, oh, you need to have a dentist. You need to know a good dentist because they're like having a good mechanic, right? Because when something breaks with your car, you don't know. Like your alternator is broken. I'm like, oh, okay, sure. Like I don't know anything. I'm not mechanically inclined. I don't know anything. And a lot of patients don't know much about their teeth, right? They just trust their professional. And much more often I found they trust their hygienist more than they trust their dentist, because you guys do such a great job of having a relationship with your patients, right? The dentist pops in and out and then they're gone, right? Whereas you guys see your patients on a regular basis. And so, I think if you guys discuss this with your patients, it'll go a long way in terms of gaining their trust. And I'm not a voodoo kind of guy, like, ooh, you better do this or else, right? People say, oh, my dentist said I have to get this graft and my tooth is going to fall out. And I almost want to be like this, like, your tooth is not going to fall out because of recession, right? I mean, recession I'm not minimizing it. Having recession is not great because you can have root caries on it, you can have periodontal disease develop on it, you can have progressive recession, which can make things worse and harder to treat. So I'm not minimizing what I do by any means, but at the same time, like in a span of 6 months to a year, a tooth that has 3 millimeters of recession is not going to fall out of the patient's mouth, right? So, I always say, educate the patient, let them know what the problem is, let them know what their options are, and then if they see the value in what you're recommending, then they're 100% going to do it. Right. And that's my approach. I'm not a do this because I said so kind of provider.
Can I ask you one other question that I've been thinking about is about occlusion. So you've mentioned orthodontics, you've mentioned risk factors. Is occlusion part of like your risk factor, your risk assessment, or how does that play into it all?
I'm going to say yes and no. Okay. So the way I trained at U of T, occlusion is not a big part of our training. I know there's lots of institutes that occlusion is like huge for them, and occlusion is the cause and treatment for everything. But the way I trained, occlusion was never a big part of my treatment. Again, so I'll mention my bias so that you can kind of see where my head is coming from. From my review of the literature, occlusion is not a cause of recession. Occlusion can cause abfraction lesions, maybe even that's kind of like on the sometimes yes or no, but I can see how having excessive forces on a tooth can lead to some kind of problems, like I said, like an abfraction lesion. But I don't think if you have hyperocclusion on a tooth, you're necessarily going to get recession. And I would say for every one tooth that is in hyperocclusion that has recession, you can find another tooth that is in hyperocclusion that doesn't have recession. So if it was a cause for it, you would expect it to happen most of the time, or if not all the time. And with that being said, I think if a tooth has existing recession and is in hyperocclusion and has thin tissue, then probably is going to progress. That recession is probably going to progress more rapidly than a neighboring tooth that doesn't have those things, right? So I think it's good to look at occlusion as a part of your overall assessment, but I wouldn't put a lot of stock into occlusion per se, right? You want to treat hyperocclusion because it's not good to have hyperocclusion. You want to take it if the tooth has excessive occlusal trauma to it because it doesn't have neighboring teeth. You want to give it more posterior support and whatever. You don't want to have fremitus. All these things. You don't want to have it because you don't want to have that for the tooth, not necessarily because you think it's going to cause recession. So yes and no. I don't know if that answers it, but again, that's a bias squad. That's a bias. That's my bias. So, I'm sure you can find someone who's going to tell you, yeah, absolutely, recession or occlusion causes recession.
No, I think you answered that very well and gave us a lot to think about, because it's not just black and white. Dentistry isn't black and white. So, there's the gray area where we have to use our thinking. We have to look at all the other factors and how it comes in. But I know I was thinking it, and I'm sure some of our viewers were thinking it as well. Sorry, Anna Louise, were you about to say something? I think I cut you off.
That's okay. I was going to say that we've talked obviously about all the reasons that we want to do it. And I know you alluded to patient selection in the very beginning being a one of your assessment strategies. Can you go over with us where you think maybe a soft tissue graft wouldn't be a good idea?
Yeah, I mean, that's a great question. Again, sometimes, you have to ask yourself why you're doing it. And the three big questions that I always ask is aesthetics, sensitivity, and longevity, right? If the patient has no aesthetic concerns and no sensitivity, then, you don't need to necessarily graft it. So patient shows up with a ton of recession in their mouth So let's try to find a case where I can maybe illustrate that. So let's pick any one of these cases that I have here. So let's say a patient shows up like, let's pick this one. So let's say patient shows up like this, lots of stuff going on here, but the patient has lots of recession. A lot of the recession is masked by composite restorations, mind you, but the patient has recession, but she has no sensitivity and no aesthetic concerns. So, and if you don't have any concerns about longevity, then you don't necessarily need to do anything about it. If you don't think that recessions are going to get worse, it's not going to. So that's how I look at it. But other reasons, if you have a hopeless tooth, let's say a tooth that has a, like that 2-4 that I showed you that was kind of completely out of the tooth, that, that's not a reason to do it. If there's other diseases going on, like if the tooth is endodontically involved, right? There's an endodontic abscess or something, right? So then don't do a graft on that. So, and I also say, like, if the tooth is severely malpositioned, trying to graft it is difficult and probably not a great idea. So those are the case selection. If sensitivity, aesthetics, and longevity are not a concern, and as long as, then you probably don't want to graft it. And if there are other restorative, endodontic, or whatever is going on, then you probably don't want to graft it either.
Great. That's more good food for thought. My goodness. I can tell already I'm going to be watching this again and again because I get more out of it again.
I know there have been a lot of questions that have come in, and is this recorded? They can't believe the information that you've provided. And yes, it will be recorded. It'll be up on the RDHU website in the next few days. So definitely, if you want to watch it again, share it with your team members, share it with your doctors, kind of bring us all together, and we can have conversations about how we can help our clients, because this has been beyond informative. Again, thank you so much for joining us today, Dr.
You're so welcome.
It has been amazing.
Yeah, you're so welcome. And I guess I just, not to be a plug, but I think there's an RDHQ thing that I did last year. Yeah, and I think it's been recorded. So I think I think you said in the fall it's going to come out.
Actually, we're going to
in the spring.
Yeah, in the spring 2022.
Yeah, so there's actually, I think it's a 1-hour lecture. So it's this stuff again, maybe in a little bit more detail. And so you can take a look at that. I think that'll also be hopefully some help.
It's great. Thank you so much.
You're welcome.
And thank you to Crest Oral-B for sponsoring today as well. We appreciate your support, and and thank you to my wonderful cast members here to come on again, and to all of you for joining us today. I really enjoyed that.
Last thing I will say, sorry, I want to let you guys go, but I'm going to put my first slide up, which has got my email address on it. I know there was a lot of content here. If you have any questions that you want to direct to me, please send me an email. I will be more than happy to answer it. But also, if you want to email RDHU, and I'm sure they'd be happy to send the email to me, and I would be happy to answer any questions you might have.
Yeah, and send them any new topics too that we want.
Yeah, tell me what you want me to talk about.
Yeah.
Yeah,
I'll have you back. Popular demand next year, 2022. All right, we'll figure out a time to put you in our schedule for sure.
Awesome. Thank you so much, guys.
Yeah, we so appreciate all of this. We appreciate your time and just the effort that you put into these presentations for us. And thank you for providing your email address, because there have been a few questions coming in. So if they want to direct those to you, or even to myself or Kathleen, we can pass that along. But we're just so grateful for the time we've had with you. So thank you very much.
You're welcome. It's my pleasure. Thanks for having me again.
Now, ladies, we have lots happening on with RDHU this coming month. I know Beth and I have our QA test prep course happening again, back by popular demand, starting on Thursdays at the end of November. On Sunday, I have my AAP classifications course. So if you haven't, or you want to brush up on AAP, definitely join me for Sundays. Anna Louise, you've got documentation, don't you have coming up this month as well?
I do. We have 2 longer sessions, 2-3 hours on a Friday, a couple of Fridays. And then in December, I have an implant program as well.
Wonderful.
That'll keep me busy. Keeps us all busy.
We have that sharpening workshop next Saturday. It's interactive. So we share our screens and our videos, and we can help you with that. So that's next Saturday.
Yeah.
And then our QA weekend.
Yes, that's
December 3rd,
December
4th. Yeah.
Yeah. So, and then we have a a 4-pillar approach, the oral systemic connection coming up as well. So there's lots of stuff coming
There's
up.
so
So
much.
check out the schedule for sure. We'd love to have you join us. For anyone asking about the CE certificate for today, we just need 2 to 3 business days to get that email out to you. There'll be a very, very short quiz to fill out, and then your CE certificate will follow. So keep an eye in your inbox, check your junk folder and your other folder as well. Sometimes our emails sneak in there. But otherwise, I hope you all have a great day. And again, thank you so much for everyone for being here, and especially for you, Dr. Hassanpour.
Thank
Yes,
you,
so much.
everybody.
Thank you.
Bye-bye.
Bye.
Bye.
Bye.